Okay, let's just jump right into this explainer. Today, we're demystifying hydroceles. For way too long, dealing with the swollen scrotum meant relying on these old-school bedside parlor tricks. But honestly, modern medicine demands precision. We need to leave those outdated physical exam routines in the past and step firmly into the era of professional, crystal-clear digital imaging.
Picture this clinical puzzle for a second. A 24-year-old guy walks into your clinic. Painless scrotal swelling. You grab a pen light, shine it through, and boom, it transilluminates brilliantly red. Looks like your textbook. Totally benign fluid collection, right? So do you just reassure him and book a simple outpatient surgery? Well, if you do, you might be walking straight into an incredibly dangerous diagnostic trap.
Here is the wild part, and it's absolutely crucial to remember. Up to 10% of testicular germ cell tumors in young men actually present with a reactive secondary hydrocele. That glowing red fluid, it acts as a literal mask, just hiding a sinister underlying malignancy. Betting on a pocket flashlight over professional, crystal-clear digital imaging is a gamble you absolutely do not want to take.
So, to lock down your clinical mastery, here is our roadmap for today. We're going to hit the diagnostic trap, anatomy and fluid dynamics, recognizing subtypes, the power of imaging, and finally, surgical management and its pitfalls. Let's get to it.
All right, part 1, the diagnostic trap. Let's break down exactly why those bedside assumptions are so dangerous.
It really comes down to the false assumption versus the hidden reality. You confidently reassure a patient based on that quick flashlight test. But then imagine you're in the OR. You make the incision, open the tunica vaginalis, the clear fluid drains out, and suddenly you feel a subtle, rock-hard 1 centimeter tumor nodule on the lower pole of the testicle. That moment right there, that's exactly why transillumination alone completely blinds you to reality.
Moving on to Section 2, Anatomy and Fluid Dynamics. To treat this right, we really need to understand the basic plumbing of why this fluid builds up in the first place.
When you look at pediatrics, it's actually pretty fascinating. A massive 80 to 90% of full-term baby boys are born with a hydrocele just because of a slight delay in their anatomy closing up. But, nature's pretty smart. An overwhelming 90% of those resolve entirely on their own by age 2. The body literally just fixes the plumbing itself over time. Now, in adults, it's a whole different ballgame. It's all about fluid dynamics. Think of the sac around the testis, the tunica vaginalis, like a 2-layered, low-friction plastic envelope. The inner layer secretes this microscopic lubricant, and the outer layer acts like a lymphatic sponge to mop it back up. That delicate balance? It's entirely dictated by Starling forces, which govern how fluid moves between those layers.
And this perfectly bridges human embryology with global health. In the womb, the descending testis drags a pouch of the abdominal lining down with it. That pouch is supposed to seal off, but if the outer lymphatic sponge of that sac fails later in life, the envelope just fills up and expands. Now, this can happen from normal aging, sure, but globally, lymphatic filariasis, a parasitic infection, causes this in over 25 million men. 25 million! It's the leading cause of acquired secondary hydroceles worldwide.
Okay, Section 3, Recognizing Hydrocele Subtypes. So we know the fluid dynamics, but how do these actually show up in our patients? You absolutely have to distinguish between these two subtypes. A pediatric communicating hydrocele is literally an open pipe right into the abdomen. The fluid goes up and down, it shrinks when the kid lies down and swells when they stand up because of gravity. But an adult non-communicating hydrocele, the valve at the top is closed off. It's just a localized, insidious ballooning that happens constantly over years.
And why is knowing the difference so critical? Because operating on an infant's hydrocele from the bottom up via the scrotum is a recipe for absolute catastrophe. A pediatric hydrocele is basically an abdominal hernia in disguise. If you cut into the scrotum, you completely miss the actual problem, the open neck up in the abdomen. You guarantee the fluid will come back, and you severely risk permanently injuring the vas deferens.
Which brings us to Section 4, the power of imaging. This is the absolute core of this explainer, swapping out physical exam guesswork for the undeniable truth of professional, crystal-clear digital imaging. The big players, both the European and American urological associations, unequivocally mandate high-frequency scrotal ultrasonography with color Doppler. If you can't perfectly feel the testis because it's hidden by tense fluid, or if your patient is a young guy under 45, an ultrasound isn't optional. It's mandatory. We need that digital scan to spot the fluid and definitively rule out a hidden tumor.
Still tempted to use the pen light?
Consider this. Thickened, chronic, or calcified hydrocele sacs simply will not transilluminate. False negatives happen all the time with chronic hematoma seals. That flashlight is going to lie to you. That is exactly why physical transillumination has to take a back seat. Always, always trust the ultrasound.
When you break down the differential diagnosis, you see exactly what that imaging is proving for you. A hydrocele wraps right around the front of the testes. A spermatocele, that sits up and behind it. Hernias give you a cough impulse, and a true testicular tumor is sitting inside the actual tissue of the testis itself. High-res imaging takes all the guesswork out of this, instantly separating a harmless cyst from a dangerous malignancy.
All right, final section. Section 5, surgical management and pitfalls. The digital imaging confirmed it's just a benign, adult hydrocele causing the patient a lot of grief. Let's talk about how to fix it safely. You can't just cut in blindly. It requires a really precise anatomical roadmap. You literally have to peel back the layers systematically. Skin, dardos muscle, the different fascial layers, all the way down until you reach that bluish, translucent sac without damaging anything else. Only then do you pull the sac out, drain the fluid, do the repair, and meticulously control the bleeding.
For the actual fix, you're usually looking at two classic techniques. You've got Jaboulet's operation, which is an aversion technique. You basically open the sac and tuck the edges behind the testes. Perfect for large, thin sacs. Or you've got P.H. Lord's famous 1964 procedure. This is a plication technique for thicker sacs where you gather the edges up like a fan. Lord specifically designed this to be practically bloodless, minimizing any disruption to the vessels.
And across all the major international guidelines, the consensus is totally unified. For kids, patients, you observe for up to 2 years. For adults, open surgery is the absolute gold standard. Notice how needle aspiration or sclerotherapy aren't the go-to? That's because their recurrence rates are just unacceptably high. But you really have to watch out for the scrotal hematoma trap. The scrotum is full of very loose tissue and has almost zero internal pressure to stop bleeding on its own. Seriously, a single uncauterized vein can bleed out and form an agonizing hematoma the size of a grapefruit. You actually need to spend way more time on meticulous hemostasis than on fixing the hydrocele itself.
Before we finish up, I have to leave you with this life-saving clinical pearl. Never, ever aspirate a hydrocele on the ward. Sticking a needle in it in a clinic setting has a 90% recurrence rate. But even worse, you risk pushing skin bacteria into a closed space, potentially turning a totally painless issue into a life-threatening pyocele or Fournier's gangrene. Just don't do it.
We've covered a ton, from fluid dynamics to surgical traps, but I want to leave you with one final, provocative question. Knowing the hidden dangers, knowing about those pediatric hernias in disguise, and knowing about that 10% tumor risk hiding right behind a wall of fluid, are you really going to rely on a simple flashlight over professional, crystal-clear digital imaging ever again? In modern medicine, seeing clearly is literally the only way to treat safely. Thanks for joining me on this explainer, and I'll catch you next time.